All right, I'd like to start with a story. And, when I talk about the hip rotators, it's not like I started off with this agenda to focus on the hip. I just pretty much fell into it. So I'm at an outpatient physical therapy clinic, and I get a new patient. And he comes to me with a script that says Achilles tendonitis. And he's a runner. He's a mid-distance runner, runs about half Ks. So I sit him down, get my notepad, and start taking notes about his history. He's had this for about 1 year. In that year's time, he's seen a family practice physician, chiropractor, and now he's seen an orthopedic physician. Also in that year's time, he's had 2 bouts of physical therapy. Every time he goes to a new physician, they send him to therapy. So now he's at my therapy. So I get his history. He's had it for a year. It's chronic. He's had everything done to this Achilles you can imagine. E-stim, A-stim, Graston, soft tissue mobilization, active release, every kind of modality, ultrasound, iontophoresis, taping, kinesiotaping, mulligan taping, every kind of exercise protocol you can do for the Achilles, eccentric training, stretching, dynamic stretching, static stretching. And all of these things helped until he would start running again. So he's on a rest bout right now. He every time again he goes to another physician, they tell him to rest. So about a mile into his run, he starts to get symptomatic. And then he can't get much further than that. He has to stop. So, I'm getting his history, and I'm thinking, great, what the heck am I supposed to do with this guy? He's had everything done you can imagine. And this is when I first started learning how to do biomechanical analysis. So I'm like, well, let's give it a shot. I stood him up, checked his foot, assessed his foot, checked his Achilles, ankle, range of motion, strength, all the stuff you do. Looked good. Get to his knee looks good. Get to his hip. I check his hip flexors, see what, if he can get mobile and extend through his hip. Looks pretty good. So I thought, well, there's not much left on the list functionally, so I checked his hip rotation, his hip rotators. And check his good side, to have him do some excursion tests, excursion distance. It's kind of within normal, what I usually see. Check his Achilles side. He had about half of what he had on the other side. So I'm like, okay, well, let's take this a little bit further. Checked his strength for his hip rotators. And for his strength, had him do some lunges, some balance and reaches, see if he can decelerate and control gravity. It's looking worse. He's starting to fall apart. So let's see how you do with some more dynamic movements. So take him to some agility drills, pump some speed up. And again, it's worse. And this time, it flares him up. It reproduces his symptoms. So that was as far as I could get him. So I sit him down, talked to him. I said, hey, you've had everything else done to this, and the only objective finding, the only thing I could see on you is your hip rotators. They're tight, they're weak, they're deficient. Let's just start there and see what happens. So I give him some exercise, give him some stretches, some dynamic movements, try to get some more excursion through those hip rotators. Comes back, he's looking better. Progress him to some strength stuff, some lunges, some rotational reaches. Starts looking better. So let's try some agility drills. Let's do that agility drill that kind of flared you up. Take him through that. He can get through it. Then I just increase it. More speed, more resistance, and see how he does. And he's starting to come along. The quality of motion looks better. His excursion distance, strength is better. So it's time for you to, let's see how you do start running again. Start with 1 mile. That's all you could do before. Let's see what you do with 1 mile. He runs a mile. Let's go to 2 miles. Start to bump it up a little bit. 4 miles, 6 miles, 8 miles, and then, he's back. He's running again. I'm just like, yes, we got it. And I started thinking, I need to be more consistent with checking hip rotation on all my athletes. And sure enough, I started seeing a consistent pattern of deficient hip rotation in my athletes, and it was a significant component to their performance and their injury. Now, this was across the board. So I'm not saying that this is like, a silver bullet. You just wave this magic wand over somebody, hip rotation, and poof, everything gets better. I've been doing this for a long time, and I know the complexity of human movement, and there's so many variables involved. But it is at the top of my list, and I have to share this with you. So we're going to take a global picture of the hip. And the hip is, it's just received a lot of attention over the last number of years. I think there's a hip course going right now as we speak, hip hinge. So it's just a big topic, and partly because they're powerful. The strongest or the biggest muscle group in your body is the gluteus maximus. So it is power. It's noted for its power on the field and in the gym. But along with that comes some problems. It's kind of predisposed to having some problems. So today, that's what we're going to do. We're going to look at the performance side and the power side. Big picture of the hip, so we'll dive into the hip rotators. And we're just going to look at the anatomy, the function, and the performance. I do have to do a quick review of the anatomy just to make sure we're all on the same page. Very brief, because I don't want to spend time on this. So you've got a little techno difficulty here. It's supposed to be a picture of the glutes and the rotators. But these are the external rotators. Sorry about the picture's not there. The piriformis, it gets the most press. It's the biggest one most people know about. Gemellus, obturators. So it's a group of 6 muscles. There's the picture. And they're underneath the glutes. And for note, these are external rotators. And here's just another view of it. I like this one because I like the orientation. And basically with this picture, what it highlights, the external rotators are the only muscle group in the human body that are oriented specifically and solely in the horizontal plane. Now, I'm leaving out muscles in your face, your abductor pollicis in your hand. Some of you may be thinking, what about the transverse abdominis? But it's kind of categorically different. It causes more of a compression. It doesn't necessarily rotate or decelerate rotation. It's the only muscle group oriented solely in the horizontal plane, so it's unique and categorically different. So let's look at the function. If you look in a textbook, look in a goniometry book for the function of the external rotators, this is what you're going to get. Okay, this is a goniometry book. If I want to measure external rotation, I have him bring his knee in and can measure a range of motion. And again, to me, this is counterintuitive because it just doesn't look like external rotation to me. And the same thing for internal rotation. You can take a measurement. If you want to check the strength of the hip, you can put your hand on the outside of his foot and apply a force and grade the manual muscle test 1 through 5 accordingly. And this is the textbook definition of the external rotators. And along with that comes implications. So those definitions that we learn in school, it works its way from the university to the clinic to the training room to the fitness center and out into pop culture. So I want to look at it. A couple of pictures. This is a picture I got out of Runner's World. Nobody gets this magazine. Got this right out of Runner's World magazine. And this is a lady with some tubing around her ankle, and she's doing resisted external rotation exercises. So I would ask you, does that look anything like running? Does that have anything to do with running? I mean, her butt is on the table, her feet are off the ground. Completely non-functional, nothing to do with running. But I fault not Runner's World for that, because if I was a journalist working for Runner's World, and I was given the assignment to do an article on the hip, how to strengthen the hip rotators, I would just Google it. I would do my research, look in a book, maybe talk to a professional, and that's exactly what I'd come up with, because that is the textbook definition of the function of the hip rotators. The next one, this is from TPI. We got any TPI people out there? No hands? Any hands? There's one. So I like TPI, Titleist Performance Institute. They train for golf. And they do some good stuff. They train you on how to analyze the swing, how to analyze swing faults, and how to correct them. They also have an exercise component. So I just went to TPI and typed in hip external rotation exercises. And this is what I came up with. So hopefully you can see it, but basically it's a guy on his hands and knees. He's doing hip extension, and his leg is externally rotated. So again, I would ask you, does that look anything like the golf swing? I mean, to me, it looks like he lost his ball in the lake and he's trying to find it. Or, I don't know, maybe the pros train the caddies differently nowadays. They train them like hunting dogs. If they find the ball, they go on point or something. Again, it has nothing to do with the golf swing. It's non-functional. If you've studied the golf swing and all the mechanics and the complexity of it, it's very difficult still to understand it. And you have to have rotation of both hips for that. The feet need to be on the ground, and you need to be training in an upright position. So my premise to you today is this, that this type of training philosophy it's non-functional. It's even dysfunctional for enhancing performance. And I want to lay down for you today a different foundation, a different approach, and it's a performance-based approach. Now, when I was growing up, my dad was a dentist, and he loved to fly, so he was a pilot. And when I was about 12 years old, he said, okay, Michael, it's time for you to start learning how to fly. So I started with takeoffs and landings. Obviously, he trained me, walked me through it, and takeoffs aren't too bad. I mean, you get that thing going fast enough, you pull back on the controls, you're going to take off. But landings are a whole different scenario. It takes a lot of training, a lot of preparation to go through it to do it safely. So he took me through it, touch and goes, did all the stuff I needed to do, check my altitude, speed, nose, wingtips. So it came to the day when it was my turn to do my first landing. So we're up, and we're quite a ways out from the airport, and he said, okay, you ready? You're up. Take the controls. And something just kind of hit me. I mean, I just panicked and freaked out. We're going to die! We're going to die! And my dad just puts his hand on my shoulder and says, it's okay. We're still about 50 miles out. We're not even close. Focus. Don't worry about the landing. Think about the approach. Focus on your approach. What's your altitude? What's your speed? Where's your nose? Where are the wingtips? How far out are we? So pilots have a saying that says, a great landing starts with a great approach. So today we're going to have a performance-based approach, and I believe we're going to have a great landing. So let's look at the hip rotators. Let's look at the performance side. And I want to come up with a performance definition of what the rotators do. Okay, so this is the performance definition of the hip rotators. Down a little bit closer. Okay, the hip external rotators simply decelerate hip internal rotation. But along with that, because the IT band's attachment to the glutes in the hip, and also the IT band attaches to the tibia, it also decelerates tibial internal rotation. So it decelerates internal rotation of the entire lower extremity. And we're going to go into detail on this. So if, we get flexion of the lower extremity. I mean, you could see it. Gravity causes it. It's pretty easy to understand. But what about rotation? What causes rotation? What drives it? And the answer is the subtalar joint. And the subtalar joint is likened to a mitered hinge. And I'm going to give you 3 examples of this mitered hinge. I'm going to explain it. I've got just a brief video of it, and I also have a working model because, it is important to what we're doing. Everything hinges on the mitered hinge. Okay, so I'm going to review just gait and running mechanics. I'm just going to use the traditional textbook model on this one. So at heel strike, when your foot hits the ground, and I'm not talking about forefoot striking, and that's a whole course in itself, but just the traditional model. Heel strike, my foot goes into plantar flexion, so that accounts for some straight up and down motion. Hopefully y'all can see this, but at heel strike, also my calcaneus, my heel everts, so I get calcaneal eversion. So there's some side-to-side motion. I'm exaggerating, it doesn't do that much, but so you could see it. So I've got this, I've got side-to-side, but that's still not rotation. Where does rotation come from? And that's the subtalar joint. The subtalar joint is the torque converter mechanism of the entire lower extremity. And what it does, what I mean by that, it takes this side-to-side motion of the calcaneus and converts it into tibial internal rotation. So it converts this side-to-side into rotation. That rotation, tibia, femur, all the way up the chain to the hip. And I want to show you also kind of a working model of this mitered hinge. Let me get a picture of it up here. Okay, so that's the mitered hinge. That's very similar to the subtalar joint. And I tried to make a model of it for you. I actually got a mitered hinge. This thing weighs about 20 pounds. It's kind of heavy. So, this is just for illustration's sake. Obviously, this is not what your subtalar joint looks like. If it's going to stay together, it fell apart a minute ago. Because it's all inside your ankle mortise, and there's just no way I could demonstrate that. But this still should illustrate the point. And also, this is going to be up on screen. Hopefully, they'll get that. So basically, let me get all the stuff out of the way here. So again, when my ankle hits the ground, this represents kind of the frontal plane portion of the subtalar joint. This piece is the tibia. This right here is the tibia. So when this hits the ground, I've got that calcaneal eversion or side-to-side motion. I'm exaggerating that so you can see it. It doesn't do that much. So side to side, but where's the rotation? Well, that's where these built in here, that's where these come into play because they're hinged and they work together. You can play that first video. And so what you get is this side to side converts the tibia into internal rotation. So another way, side to side, and that converts this into rotation. And that rotation goes tibia, femur, all the way up the chain. Okay, so again, we're going to contrast the textbook definition with the performance definition. So we're just going to pick one of the external rotators, and again, we'll do the most famous one, the popular one, the piriformis. Most people know the piriformis. We do a lot with piriformis syndrome. So if I was to look at a textbook, if I was to Google what's the function of the piriformis, this is what I'd get. The piriformis externally rotates the femur. But this is a concentric definition. So I want to give to you a quote. This is by Robert Ballard. Robert Ballard is the discoverer of the Titanic. The Titanic movie is based off of his findings. And he's given a TED Talk to like a few thousand people and just kind of explaining how he found the Titanic, all the work he had to go through and his crew. And he had to basically just buck conventional wisdom to do the extra miles to what it took to find the Titanic. And this is a quote he had. He said, "Everything I'm about to present to you was not in my textbooks when I went to school." And so we're kind of like explorers. That's what we're doing right now. And I want to look at the performance definition of what the piriformis does. So the piriformis eccentrically lengthens to decelerate or control femoral or hip internal rotation. And it makes sense. So when my foot hits the ground, again, that subtalar joint is going to convert that tibia into internal rotation. That's going to take my femur with it. It's all going into internal rotation. My external rotators in my hip, they have to lengthen to decelerate that. And it's not just the femur, it's the tibia as well. So they have to decelerate the entire lower extremity. It lives in the eccentric realm. I mean, that's where it functions most of the time. So that's more of a performance definition. So I want to talk about how this relates to sport, how it carries over to sport. And the title of my talk is Hip Rotators, Friend or Foe. And when I say friend, what I mean by friend is the hip rotator's primary role in performance and just how it benefits performance. And we're going to look at about 3 different points. I'm not going to spend a lot of time on it, but it does a lot of things. But one of them is ground reaction forces. The biggest controller and decelerator of torque and rotational moments, and I'm spelling that M-O-M-E-N-T-S, not movements. That's a vector of force. Going up the chain is decelerated by the hip external rotators. They're the biggest and bestest. No, that's not a physiological term, but they are the controllers of that motion. I was on the treadmill a while back at the gym. It's about the only time I get to, got the little TVs, the only time I get to watch TV, and they have the movie Death Race on there. And if you haven't seen it, basically it's a gel setting, and they've got these inmates that race each other in these cars. They build them up with armor and weaponry and missiles and guns, and it's set up in an entertainment venue so the rest of the world can watch it. And they had the warden in this movie, would set up in the warden's tower and control the whole race. And the warden woman just had, if you know what I'm talking about, she had the scariest and the meanest looking face. She controlled everyone and everything around her. Super control freak. And that's kind of like your hip rotators, but in a good sense. They control everything that goes further down the chain. And your posterior tib, down in your ankle, distally, it can get to those forces first because of its proximity to the ground. But you do not want the posterior tib doing all the work because it was not designed to do it. I mean, which is bigger, your hip or your ankle? There's a certain politician running for office that said to have cankles, but I won't go there because half of you will just get mad at me. But the hip was designed to control that, not the posterior tib. And if it has to compensate for your hip deficiencies, then there's going to be increased stress, tendinitis, and injury. So another component would be attenuating forces. It basically decelerates forces that otherwise would go to the knee. The protector of the knee is the hip. The hip controls and protects everything further down the chain, especially the knee. All these quotes, everything's in the notes online. The key to a strong ankle is not, ankle alphabet or doing TheraBand exercises down here. The key to a strong ankle is a strong hip, and especially strong hip rotators. If you want to have protection down at the ankle, you also need to look at the hip and train the hip as well, because it, again, protects all the structures further down the chain. And the hip rotators and the hip itself is essentially the most important muscle group in regards to performance and injury prevention, and that's kind of why we're here today. So, rotation in sport, what does that look like? I talk about this subtalar joint and all the torque and moments going up the chain, but I want to give you some visuals just to better illustrate it. Okay, this is a picture of Sue about to rip Cutler's head off. And so if you look at this picture, you can't really see what Sue's foot's doing, but his right foot is either on the ground or about to hit the ground. And as that right foot hits the ground, it's going to get driven. The subtalar is going to drive it into internal rotation. So the hip has to lengthen to decelerate and control that. But not only do you have that, but he's also reaching that left hand across. So he's got ground reaction forces from the bottom up that the hip is helping to control, but he's also driving it from the top down. So that's really winding that hip up. And that hip has to be mobile and strong to control that motion. Sue's going to need his friends, so to speak, to help out with that. And I'm not talking about the other guys on the line. I'm talking about his hip and his hip rotators. And if they're not doing it, then he's going to have some problems. So soccer picture here, I got Cristiano, and I'm looking at his left foot or his plant foot. So he's kicking the ball across his body, and if he was kicking the ball straight out like this, I would be looking at his left hip, but more his hip flexors to see if he could extend through his hip. But because he's driving it across his body, my pelvis is going to rotate towards that side, and it's driving this hip into internal rotation. Those external rotators are going to have to lengthen to control and decelerate some of that. So I love this picture because of the way that left foot is pictured. It's still up in the air. It's just about to crash into the ground and slam down. And as he does that, that's going to drive the tibia into internal rotation forcefully and fast. So that's going up the chain. But not only does he have this, he's also got his other leg driving across. So bottom up, top down, they meet at the hip. And if that hip is not strong enough or mobile to decelerate and control that, then I just can't emphasize enough. 90 minutes of start, stop, cut, kick, all the stuff they have to do. If there's a minor deficit in that hip, it will eventually show up, either in just decreased performance or an injury. Next one is golf. I got Rory McIlroy here. I love Rory's swing. If anybody has studied his swing, it's one of the coolest swings on the tour. He's got this double whip thing going on. He can't even make that happen himself. It's amazing. But again, as he follows through, on the golf swing, as you follow through, there's a little arrow there. It's going to drive that left hip into internal rotation. And with this swing, because of the force of it, he is taking that hip joint to its infill as far as it's going to go. So again, those hip external rotators, they need to be mobile enough to get that motion. And if it's not, then there's going to be problems again. He's either going to have to slow down that swing. He's going to, as his club head comes here, it's going to be decreased club head swing because his hip's already saying, I'm not going to be able to handle that motion. So he'll start slowing it down too soon, or he's going to externally rotate his foot to bail out. He won't have something going through his hip. His back can take it. Those forces get dissipated somewhere else. Knee, Achilles. He's had all those injuries. No, I'm sorry, that's Tiger Woods has. And probably the easiest sport kind of to see this rotation is baseball and the baseball batting swing. So, if I was given the mandate to strengthen this player's hip external rotators, his hip rotators, and I was to use the conventional concentric approach, I would end up detraining his swing because it requires an eccentric approach. If you can increase his ability to eccentrically lengthen the tissue and do it while it's loaded with some resistance, he's just going to be able to hit the ball farther. And you could quantify this. You can quantify it with video motion analysis. I love video motion analysis. And with force plates, or ultimately just how far he's going to jack the ball. Okay, but we do have a dilemma, and it has to do with rotational sports. Now, this whole phrase is kind of a trend that's just developed over the last number of years. Like 10 years ago, if you asked a trainer, personal trainer, or an athletic trainer, do you train rotational sports? They just, I train athletes. What are you talking about? You know. Now there's a whole specialty for rotational sports, and so you may be saying to yourself, the refutation is, well, I don't train rotational sports. I just got somebody in the gym, or I just do fitness, or I just train basic strength, squats, all that kind of stuff. I don't do rotational sports. But my point is, going back to my first point, every foot strike leads to hip internal rotation. So it's not just these powerful rotational sports. It's not swinging a bat or swinging a golf club or any kind of super powerful rotational motion. Every time a football player goes 10 yards, you have internal rotation. Every time a basketball player cuts across the court, there's internal rotation. Every time somebody is on the treadmill in your gym, there's internal rotation. Every time they walk into the gym, internal rotation. Those external rotators get lengthened, and they have to, there's just no way around it. You cannot get away from it. Internal rotation is part of human mechanics. Okay, so that was kind of the friend side. So I want to look at the foe side. What happens if the rotators are having problems? So we're going to look at the deficits, and I've got it into two categories, intrinsic and extrinsic. So intrinsic basically is intrinsic to the rotators themselves. It's inherent in the muscle tissue. Extrinsic would be more the biomechanical factors that cause them to be tight. And we're going to start with intrinsic. So this next slide is, it's kind of physiologically complex. I have to go into the kinematics of the hip joint. I also have to look at the action potential of the neuromuscular junction. So, all my notes are online. Please don't strain yourself taking notes. Okay, so you ready? So the hip rotators are tight. That's it. Simply put, they're just tight. But I'm telling you, this has huge side effects. And this next slide really is probably the most important slide because it kind of underscores everything we're talking about. If they're tight, it's going to cause decreased internal rotation. So if this was like the old days when they had the national conventions, you used to get a big old thick book with everybody's slides in it. I mean, you could cut a hole in that thing and use it for a plate for deadlifts. It was huge. So if you had those, I'd make sure everybody had some highlighters. And because this slide is so important, I'd just be highlighting the heck out of this. Because if you have decreased internal rotation, that's what it's going to cause if your rotators are tight. This is bad. I mean, very bad. We're talking like Armageddon. We're going to die, that kind of bad. Actually, a few deaths have occurred because of this. ACL deaths, Achilles tendon ruptures, career-ending injuries happen because of decreased internal rotation. I mean, do you know what it's like to recover from an Achilles tendon rupture? You may make it back, but you may never be. So we'll look at some of the implications of this. Just a couple biomechanically. One would be the ACL, and deceleration of the ACL does not occur at the knee. Deceleration of the ACL occurs at the hip and the foot. Remember, the hip attenuates forces that otherwise get sent to the knee. And if the hip is not doing its job, then the ACL is going to take the hit. Increased demand on the IT band. So usually when we think of the IT band, we kind of have the traditional model. We just look at the IT band separate from the rest of the lower extremity. And we start thinking, the exercise where you do the stretches, everything's kind of in the frontal plane or side-to-side type stuff. But the IT band is heavily influenced by the hip and the hip rotators because of its attachment here. So I propose to you that the IT band is more of a rotational problem than it is a side-to-side problem. So I just kind of want to just explain it a little bit differently, a different way to look at it. And Got my little railroad tracks here. So this component represents the tibia. This component is your femur. And we've got your, make sure I do these right. This is going to be your hip joint. This is your knee joint. So when my foot hits the ground, we'll have some of this up on the slides there. When my foot hits the ground, that subtalar joint is going to take my tibia into internal rotation. Tibia takes the femur with it. That goes into internal rotation. Internal rotation at the knee and the hip. But if these guys are moving together, that's net zero at the knee. That's no internal rotation. It's just that this component, I think it's showing it up there, there's a little bit of play in the joint, just like in this track. So because the tibia is going, of its proximity to the ground, it's going a little bit, it's going sooner and maybe a little bit further. So we have internal rotation at the knee. But if your hip this is my right leg, if my hip external rotators are tight, that's going to limit the femoral component from its normal rotational mechanics. And because of those mechanics are thrown off, you've heard of IT band friction syndrome. It's really more of an IT band compression syndrome, and that's what some of the research shows, because it gets just over-compressed because that rotational component. But usually we're not thinking about that. We think side-to-side stuff. We're not thinking rotation. And we've also got patellofemoral. The patella is out of sync, so you get patellofemoral problems. So we're going to look at the patellofemoral more from a rotational perspective. And kind of the traditional way of looking at the patellofemoral is just straight up and down sagittal plane movements. And we've got all the studies out of Cincinnati with the jumping and landing mechanics for the ACL as well as the patellofemoral, and they've done some good job on putting protocols together. But let's look at it from a rotational perspective. So again, I've got my tibia, I've got my femur. But this time I got the patella in here. I've got Thomas. He's going to be the knee. He's going to be the patella. So my external rotators are tight. Thomas is on the track. I've got him on the track this way. It's really more like this way, but for illustration purposes, he's on the track. And when my foot hits the ground, everything goes into internal rotation. And Thomas normally, the patella normally gets bucked laterally, lateral translation, that's normal mechanics. But if he gets bucked a little too far or not far enough, or he's kind of bound down in the joint, then you're going to have some problems. And usually when we look at the patellofemoral, we're looking at straight up and down, we're looking at the VMO, the hip's not even in the picture. So what I want to do is I want to kind of compare the rehab training philosophy to like if you're a railroad track engineer. So here's what we get. Set this up real quick. So the rehab side, we are going to try to fix the patella. On the engineering side, we're going to try to fix the engine, fix the train. On the rehab side, we're going to mostly focus on the patella, and the hip and the foot, they're not part of our philosophy. On the engineering side, we're going to fix the engine. We don't need to worry about the track. So on the rehab side, we're going to do all of our knee modalities. We're going to do joint mobilization, cross-friction massage to that patella. We're going to strengthen that VMO. Everything's at the knee. On the engine side, we're going to get those wheels aligned. We're going to make sure that that engine's lined up. So on the therapy side, we're going to get our tape out. We're going to use some tape. And, it's like I could almost picture these engineers. We got to make sure that that engine stays on the track because it's just not stable. It's not aligned right, so we got to make sure it stays on the track. So I picture them with this huge piece of tape. They put it on one side of the train, get it down, they get on the other side. So they've got that train down on the track, just as we do in therapy with our patella, which it has merit. I've done a lot of taping with it. But, and I can almost picture the engineer up in the tower saying, radio saying, guys, wait a minute. The track is off. It's not the engine, it's the track. And they're just looking up, we can't hear you. It's fine. The engine's fine. It's stuck on there. It ain't going anywhere. And same thing on the rehab side. We've got the knee taped down. We don't need to worry about the hip. And then once that athlete, or if there's an injury there, they go back into sport, and they have to engage the rigors of the sport and what that knee has to go through. The patella is fine, but everything else, the track is off. So my point is that, what about the hip? The hip is the influencer of the track, of the femur. If those hip rotators are tight, then that patellofemoral is going to have some problems. So our athletes, your clients, are in desperate need of trainers that won't just look at the smoke at the knee. They need somebody that's going to put out the fire and address the hip. Okay, a couple other components. Ankle sprains, I'll talk about that in a minute. Posterior tib, I talked about that. Hamstring strains, I got to keep moving here. Yes, and I'm saying hamstring strains. So traditionally, when we think of the hamstring, everything's straight up and down in the sagittal plane. But the hamstring is also a rotational muscle. I'm going to explain it, but it's hard to deprogram somebody into, we have this hamstring dogma that everything's straight up and down. But if you think about the hamstring anatomically and functionally, it's also a rotational muscle. Because of its attachment to the tibia laterally and medially, so that foot hits the ground, takes the tibia into internal rotation. That internal rotation stimulates the hamstring. It lengthens the hamstring, and that hamstring functionally helps to decelerate tibial internal rotation. It's not just this. It's decelerating collapse of the entire lower extremity. And if you think about, how much hamstring length does an athlete need? Do they really need the recommended 70 to 90 degrees? I'm from Oklahoma. I can't even say Kevin Durant's name right now, but Kevin Durant fan. I still am. If KD is running down the court and he's going to slam one on somebody, he's not going to be trying to get his leg way up to his face. He doesn't need that much motion. I've got an athlete right now. He's a running back. He's had a hamstring problem for over a year, and it's chronic. And he's had every kind of therapy done to it. He's got a great orthopedic physician. He actually did one of those PRP injections, platelet-rich plasma, right into the hamstring. It was a good idea, but it didn't help because there's other biomechanical things playing into it. And if you've worked with track athletes, I like working with track athletes, hurlers. When does the hurler strain their hamstring? Is it are they trying to get that leg up over the hurdle? No, it's when their foot hits the ground. That's when you see them pull up and strain the hamstring. The foot is on the ground for like 16/100ths of a second when they're sprinting down the track. And a lot has to happen in a short amount of time. They have to decelerate gravity, ground reaction forces, momentum, prep that other leg to swing through. And that's when stuff happens. So I've seen people with normal hamstring length, and their hip rotators are tight. You get their hip rotators coming along, the hamstring says, okay, thank you, you just took the stress off of me. And if somebody is sprinting down the track, they're a hurdler, they don't need to necessarily have that leg all the way up to their face. You just want them just nice and relaxed, so they're just gliding over that hurdle. I think I have a video of that. Maybe? There it is. Okay, we'll keep going. All right, extrinsic. Extrinsic has to do with the biomechanics. This is my favorite part. I love the biomechanics. And we're going to go to the knee. So again, we have tight and weak external rotators. If the external rotators are tight, then what do we have? Subsequent decreased internal rotation. And if there's decreased internal rotation at the knee, it's going to wreak havoc at the knee. It's literally a biomechanical tug of war. And I want to look at two biomechanical factors that can play into that. I see these quite often. And one would be a leg length discrepancy. So my left leg is longer. The normal compensation for a long leg is for that leg to pronate more. It's just going to crash into the ground a little bit more pronation. It's not necessarily bad, but it's not necessarily good. With that pronation, though, they're going to have increased, it's going to take that tibia into more internal rotation. So what do you have? You've got the foot crashing into the ground. You're going to have the tibia saying more internal rotation. But those external rotators are tight. And it's saying more and more down here, but he's saying, I'm not going to give that to you. You're not getting it from me. So at the knee, it's literally like a tug of war. Increased rotational moments going on at the knee. All kinds of problems can happen because of that. We've discussed most of them. Patellofemoral syndrome, tendinitis, chondromalacia, quad strains. For some reason, in quad strains, I've seen that leg is longer. I don't know if I can always explain it biomechanically, but it seems more of a pattern than a short leg. Not that they all have leg links, but it is more predisposed for that. IT band syndrome, I talked about that. Okay, so we'll go to, on the other end of the spectrum, leg length discrepancy, and this time the leg is shorter. So a normal compensation, if my left leg is shorter, I'm going to externally rotate. I'm going to stand in an externally rotated position. That functionally lengthens the leg. But if I'm standing externally rotated, what does that do to my hip rotators? They get shortened. They just get tight. So then we start that whole cascade again of what that causes. Decreased hip internal rotation, bad, very bad, highlight that. ACL, meniscus, hamstring strains. I got hip flexor and Achilles. This is not the knee, this is above and below the knee. I forgot to mention that guy with Achilles tendonitis. He did have one biomechanical deficit, and that was that leg was shorter. So it was externally rotated, and that's why his hip rotators were tight. It didn't occur in a vacuum. Okay, so I want to look at another piece of the puzzle, and this has to do with extrinsic, and I call this coupling. Basically, coupling is where not only do you have the tight external rotators and subsequent decreased internal rotation, but you also have layered on top of that biomechanical deficits that just exacerbate the problems. And we're going to talk about the foot. The foot locks up the hip, and the hip shuts down the foot. And I want to look at one piece of the puzzle that's often overlooked, but has monumentous problems as far as shutting the hip down. And there's a lot of foot types we can talk about, but I'm just going to focus on one, and that's a compensated forefoot valgus. And let me explain that. So a normal foot, if I look at my rear foot compared to the back, it should be straight. It shouldn't be turned in or out. If I look at the front part of my foot, it should be flat like this. It shouldn't be turned up or down. A forefoot valgus is where the forefoot, this first ray, is turned down. Hopefully you can see that. So it's everted in relationship to the rest of the foot. But the goal of gait and running, when we heel strike, we want to get that big toe to the ground so we're propulsive for the gait cycle. But if this guy's dropped down, if it's everted, it's getting there before everybody else does. And he's taking just more ground reaction forces. It's taking it all right here. And that's not good. But our good buddy, the heel, the calcaneus, comes in and says, I got you covered. And he compensates by turning in. So that gets this whole first ray either off the ground quicker or just a little bit less force going through it. But if that happens, then there's, it's kind of robbing Peter to pay Paul, then a whole host of problems can occur. And one of them is a stress fracture to the fifth met. Again, Kevin Durant had this. His was not at the met, it was at the base. It was a Jones fracture. He had 3 surgeries for that. He finally got it fixed, but does somebody, what about the biomechanics of that? Because if this calcaneus is turning in, that's going to put all the force on the lateral border of my foot. So it's going to take all the stress right here. So again, this is a lecture on hip rotators. It's not on the foot. So what does this have to do with the hip? Well, if the hip rotators are weak, then there's just going to be more force down here. That's why it's called a stress fracture. So, what is causing the stress? Are we just going to surgically repair it? Yes, you need to do that. But what about all the other stressors, the biomechanics that play into it? And the primary one that we see with this kind of foot type is lateral ankle sprains. So again, this guy's turning in. The lateral border takes all the weight. It takes all the load. So if somebody has chronic ankle sprains, I usually check to see if they have this foot type, and it can be prominent. Not always. They can compensate, but it does play. And so what, though? I'm not talking about the foot. I'm talking about the hip. What does this have to do with my hip rotators? Well, in the lab, we're going to do a drill in about 3 o'clock, agility drill that this is where it shows up. So if I'm doing a ladder drill, I have to go out and reach across like this. All my weight is going to that lateral border of my foot anyway. But if I've got that forefoot valgus that's compensated, the foot, my external rotators are going to help decelerate and control that motion. But if they're weak, if they're deficient, I might just keep going over. And I see that a lot clinically and on the field. Okay, so we're going to have a hip approach. You know, in a clinic, I would treat that with some orthotics and stuff, but we can't always treat the cause, but we can definitely treat the compensation, and the compensation is always at the hip. But we have a problem. And the problem is the hip is not being addressed. So if somebody comes in with a stress fracture to their 5th met, it's all going to be like towel crunches with your toes, and I'm telling you, that ain't going to cut it. The hip, though, is usually not addressed. It's not even the picture. If somebody has an ankle instability, it's just going to be a bunch of TheraBand exercises here, and the hip might as well be on another planet. If somebody has, Achilles or chronic ankle sprains or a hamstring, if somebody has a hamstring, it's just going to be a bunch of this kind of thing, a bunch of this, but there's no hip rotation. If it's not being assessed, it's not being addressed. So there's lack of assessment, lack of training. I've got just a couple pictures here. I'm from Oklahoma. This is OU training camp. I've been to it, watched it. They do some great drills, ladder drills, stuff we all do. But do you think there's any exercise, any drills to facilitate hip rotation? There's none. It's not happening. It's all traditional stuff, even though it's good stuff. Some of the current training trends. If you look at her form, it's like perfect form. Good strength, those are good drills, good exercises. Any hip rotation, anything to facilitate hip rotation? None. It's not happening. And FMS, I don't want to discount the validity of these tests. I don't want to discount the research behind these tests. It's the most widely used tests. They work. However, there is not one test to quantify rotation of the lower extremity. Not one. So it's a huge void. It needs to be addressed. We need to be looking at it. Got about 1 more minute. How am I doing? Almost there. Okay, so our strategy. I'm going to just compare performance to the traditional approach. So if you were to look up, just Google hip rotation exercises. I like to watch YouTube. Before I came, I want to see if there's any new hip rotation. I YouTube some hip rotation stuff. This is what you're going to find. Textbook stuff right there. What you'll see online, what you see even in the textbooks, especially the online stuff, but that's like Barnum and Bailey Brothers circus tricks. It's antiquated. It's not sufficient to deal and address the hip rotators, sufficient enough for athletes, especially the rigors of their sport. So we want to have a performance-based approach. Almost there. We're going to keep the foot in the picture. We're going to have an eccentric approach, eccentric agility, eccentric explosiveness, and eccentric strengthening. So at 3 o'clock, we're going to do some agility drills. We're going to do some strength drills. We're going to do some more performance, dynamic type of stuff. And I don't have time for questions now. Obviously, it went over, but I can hang out afterwards or at the lab time. So thank you. Thank you very much.